So I have two topics to go to this afternoon. The first one is going to be pediatric gastrointestinal imaging. I tend to go a little tiny bit over on this talk, but I'll make it up on the next talk. And so we'll finish on time for my part, I promise you that. A couple of things. You're going to see a little bit of repetition in some of these cases. Every year I carefully watch and I try the next year to not duplicate cases, but there's some overlap this year. But I think you should take that as a positive thing, that it's probably something that we're all considering important. And so sort of focus a little bit onto those cases. I have some unknown cases for you. We'll go through these real quickly. Here's case 1. Case 2, case 3, ultrasound in the right upper quadrant. Case 4, ultrasound in the right upper quadrant. And case 5. Okay, so with this talk, I'm going to try to cover the newborn abdomen, some common urgent and emergent abdominal problems in children. I'll go through that real briefly because Dr. Patel did a nice job of talking about a lot of them. I'm going to talk for a moment about pediatric liver and biliary abnormalities, and I'll cover abdominal masses in the next talk. The normal newborn abdomen, please remember that you want to see monotonous polygons of gas throughout the abdomen. The diameter of the bowel loop should be less than the distance between the pedicles at about T12. You cannot reliably tell small from large bowel except for the stomach and the rectum, and you will be burned if you try to do that based on the position in the abdomen. So I caution you to try to not tell the bowel small from large bowel. Necrotizing enterocolitis, Dr. Patel talked a little bit about this. This is an idiopathic enterocolitis seen in premature infants. Its mortality is up to 30%. The exact etiology is unknown, but it's probably a combination of hypoxia, infection, and something related to feeding, some kind of substrate. It is very rare to see necrotizing enterocolitis in babies that haven't been fed. So again, that first few days of life, it is very unusual to see necrotizing enterocolitis. It's a transmural infection that starts on the mucosal side and then spreads. It's most common in the right lower quadrant, and it is usually patchy. The signs and symptoms can be anything from abdominal distension to intolerance of feeds to blood in the stool or bloody emesis, lethargy. They can go as far as having a black abdominal wall. And that's what case 5 was here, where you can see there's pneumatosis involving bowel loops, especially in the right lower quadrant. Now, pneumatosis is not the first thing you see with necrotizing enterocolitis. It's usually you see a focal ileus, a fixed dilated bowel loop. When you start seeing pneumatosis, you're starting to see some of the bad complications of necrotizing enterocolitis. Once the infection spreads and the pneumatosis spreads, it can be picked up by the mesenteric venous system, and that's how you end up with portal venous gas, which you can see here. It's branching pattern going peripherally in the liver. And the most severe finding is that you end up with a bowel perforation. And here's a pneumoperitoneum with the football sign. I caution you, on every single chest x-ray on a baby you look at, draw a line across the liver. It should stay the same whiteness. If you see it getting darker, worry that you're dealing with a pneumoperitoneum. You can also see a little bit of a wriggler sign here, and you can also see air along the falciform ligament. Next, I'm going to talk about abdominal wall defects. The closure of the abdominal wall in the fetus involves 4 folds that come together at the umbilicus. There's a cephalic, a caudal, and 2 lateral folds. If there's a cephalic fold defect, that's the pathology of Cantrell, and those patients usually have congenital heart disease, they have a ventral hernia, they have sternal defect, they have part of their pericardium and part of their diaphragm missing. Lateral fold defects may be either omphalocele or gastroschisis, and the caudal fold defect, you end up with a cloacal exstrophy. Case 2 that I showed you is an omphalocele. It's a midline defect covered by peritoneum, and here you can actually see the umbilical cord going right into the apex of this soft tissue mass in the abdomen. The size and the contents are variable. It can be bowel, it can be liver, it can be other organs, typically not the kidneys. 2/3 have associated abnormalities, either cardiovascular or chromosomal abnormalities, and they usually all are malrotated, although surprisingly for the diaphragmatic hernias and the omphalocele and the gastroschisis, even though they have malrotation, it's very, very unusual to see a midgut volvulus in those groups. Gastroschisis is a lateral fold defect, usually on the right, next to a normal umbilicus. It's probably a vascular accident. You see infrequent associated abnormalities. The only bowel herniates into the defect, and it is not covered by peritoneum. Because of that, the bowel is exposed to amniotic fluid, and you'll get a very strong fibrotic and serous response with an inflammatory peel, and there can be neuronal disruption of normal bowel peristalsis in the bowel that was out in the amniotic fluid. So even after they repair these patients, there can be some difficulties related to this lesion. Here's an example of a gastroschisis. You can see the umbilical arterial catheter coming in and the bowel defect with soft tissue mass to the right of the umbilicus. We're going to march our way down through some of the enteric obstructions in the newborn, starting up high and ending down low. The first one is the esophageal esophageal atresia, tracheoesophageal fistula, which is usually a combination. It's not that common to see a pure esophageal atresia. It's usually suspected early on because of maternal polyhydramnios, because the fetus cannot normally swallow the amniotic fluid. The patients will present after birth with drooling and coughing and choking, and they're unable to feed. You cannot pass an NG tube. Half of these patients will have associated anomalies. The most common esophageal atresia, tracheoesophageal fistula, is the proximal esophageal atresia, distal tracheoesophageal fistula. And here's an example of a patient that has a proximal esophageal atresia. You can see the distended, air-filled proximal esophageal pouch. Air is great contrast. We use it where we can. And here you can see another patient that has the proximal atresia with the esophageal catheter only to this level. But you can see that there is a distal tracheoesophageal fistula because you see air in the distal esophagus and in dilated bowel. This patient also has associated vertebral segmentation anomalies with a hemivertebra, and you can see that there's multiple dilated bowel loops because this patient had an imperforate anus. The heart is not visualized here, but this patient did have a VSD. There can be associated renal anomalies and limb, usually radial ray abnormalities in patients with the VACTERL association. And just for kicks, this patient also had bilateral dislocated hips. Here's a patient with esophageal atresia without a tracheoesophageal fistula. You suspect there's no distal tracheoesophageal fistula when you do not see any bowel gas. And this is more associated with Downs patients. The H or N-type fistula is an unusual fistula that you will see, and it is basically a patent communication between the esophagus and the trachea. And when you're looking for this, you have to be very aware that it can be present because you need to look on your upper GI during the first swallow. The contrast that goes into the esophagus squirts back up into the trachea. So if you're not watching, you may think that the patient aspirated rather than this being a fistula. These patients will often present with recurrent pneumonias, and one other clue that I use is that if you look at the chest x-rays along these recurrent pneumonias, you'll see that they always have a lot of bowel gas. That as easily as the fluid goes from the esophagus to the trachea, the air goes from the trachea to the esophagus, and these patients have aerophagia. Intestinal obstruction is the most common abdominal emergency in the newborn period, and these patients present just as you would expect with abdominal distension and poor feeding and vomiting. And we try to classify them as either high, which is above the distal jejunum, or low, which is below the distal jejunum. The proximal lesions, I like to think logically and march my way through from one end to the other. So we're going to start at the stomach. You can have a gastric atresia or a web, pyloric stenosis, duodenal atresia, stenosis or web, duodenal duplication cysts, malrotation and midgut volvulus, and jejunal atresia or stenosis. The duodenum is a solid tube at 3 to 6 weeks of gestation. If it doesn't recanalize, then you get an atresia. If it partially recanalizes, you'll have a stenosis or a web. 80% occur just distal to the ampulla of Vater, and there are frequent associated bile duct or pancreatic abnormalities, such as an annular pancreas or a preduodenal portal vein. There are other associated abnormalities, other intestinal atresias, heart disease, the Vactoril Association, and about 30% of these patients will have Down syndrome. Here's an example. Again, air is great contrast. We have a classic double bubble sign with a esophageal catheter clear into the duodenal bulb. This patient did get contrast, and it sort of looks like the top of a frosty ice cream cone where that atresia is. But you can see there's chronic dilatation of the duodenum, and that's what gives you your duodenal bulb or your double bubble sign. The duodenal web is more common in the Downs population, and what it starts out as just a diaphragm with a hole in it, and when the babies are little and they're just drinking liquid, the liquid goes through that okay. But then as they start to eat some solid food, little particles will get caught behind that hole, and you'll start to stretch the diaphragm, and you'll finally end up with a big pouch or windsock deformity with a small hole. And then as the kids start eating things like Cheerios and peas and things like that, it gets blocked up and they have vomiting intermittently. And here you can see that windsock deformity with the normal caliber duodenum beyond that. If you remember one thing from the pediatric lectures, please remember bowel rotation and malrotation and midgut volvulus, because this is a lesion that will kill a child. The bowel returns to the abdomen at 4 to 10 weeks of gestation, and it does that after it's herniated out into the yolk sac by making 3 counterclockwise 90-degree turns, and that gives you your normal duodenal sweep with the duodenal jejunal junction fixed posteriorly by the ligament of Treitz and a long, small bowel mesentery extending to the right lower quadrant. And that's why your bowel doesn't twist, is you have this nice, long, fixated mesentery. When we do an upper GI, we watch on every single baby and every single child to make sure that we see a normal position of the duodenal sweep. On the lateral view, the duodenal bulb is still intraperitoneal, and then when we get to the end of the duodenal bulb, we are retroperitoneal. The duodenum should come down posteriorly, cross the spine posteriorly, and go back up posteriorly, all retroperitoneal. When we turn the patient supine, the duodenal jejunal junction will be to the left of the midline at the same level as the posterior part of the duodenal bulb or the initial retroperitoneal part of the duodenum. You've got to see that. If there's malrotation, instead of having your nice long mesentery extending from the left upper quadrant to the right lower quadrant, you have a very short mesentery. What's contained in that mesentery is the superior mesenteric artery and superior mesenteric vein. So because the mesentery is short, the bowel can twist. When it twists, it cuts off its blood supply. And this is a patient, this is a slide of somebody that was having, probably they thought mesenteric ischemia. It's an adult patient, but this was a midgut volvulus, and it looks like a braid as that superior mesenteric artery and its branches are twisted because of the short mesentery. 75% who have malrotation who are going to get a midgut volvulus do it in the first 6 weeks of life. And the classic history is acute onset of bilious vomiting, and it can occur in the first day of life. The diagnosis, again, is made with an upper GI series. Here's a 5-day-old who was eating normally, suddenly developed bilious vomiting. You can see there's a disproportionate bowel gas pattern, dilated stomach, only a little bit of gas beyond. Think about an obstruction with that pattern. Here's the upper GI, and you can see the classic corkscrew appearance of a midgut volvulus. This is our case 1 unknown, jejunal atresia. We have a dilated proximal bowel, Not a lot of distal bowel. How do I tell it's proximal and not distal bowel? A few loops versus a lot of loops. This is just a few loops. And you also have to notice that this patient has had an in utero perforation because we can see a meconium peritonitis with a meconium pseudocyst here. Distal bowel obstruction. We're going to start at the ileum and we're going to march our way to the rectum. So ileal atresia or stenosis, meconium ileus, colonic atresia, functional immaturity of the bowel, which is the general classification that includes both small left colon and meconium plug, Hirschsprung's disease, and imperforate anus. The study of choice is a contrast enema, and the question you're trying to answer is there a microcolon? If there is a microcolon, it means no succus entericus got into it, and that implies a high-grade distal ileal obstruction. Here's a patient who has ileal atresia. You can see that there's dilated bowel loops on the right side of the abdomen, less but still dilated bowel loops on the left side of the abdomen, and there's lots of loops. So we're thinking about a distal obstruction. A lot of people would want to say, oh, that's the right colon, but you can see here by this enema we have a microcolon, we have a few loops of non-dilated small bowel, and when we get into the mid-ileum, we then have the dilated ileum behind it. So this is actually ileum, not colon. Meconium ileus is due to inspissation of abnormal thick meconium in the distal ileum and colon, and it's seen in patients with cystic fibrosis. Only a small percentage with cystic fibrosis, however, present with a meconium ileus at birth. Once you get the terminal ileum and right colon all gooed up with this thick meconium, it can twist, it can perforate, you can end up with meconium peritonitis. Now, the only thing meconium peritonitis, meconium ileus, and meconium plug have in common is the word meconium. Think about them differently. It's sort of like Chiari 1, Chiari 2, Chiari 3. It was just the same pathologist that described three very different lesions. Here's a patient that has meconium ileus, lots of dilated bowel loops, distal bowel obstruction. We do our enema, and we can see that when we come over into the right colon, we have multiple filling defects going back into the terminal ileum, meconium ileus. Here's another one where we see a microcolon, and as we come over onto the right, we can see filling defects nicely back into the terminal ileum. Now, in these patients, an enema can help. In about half of the patients, if you can just get some contrast, water-soluble contrast around the meconium, you can sort of lubricate it up and crack it up so it'll pass. And that can be very helpful. And you may have to do several of these enemas to get this to happen. But the only alternative they have is going to surgery, where the surgeon will either try to milk the meconium forward into the colon or may end up having to resect bowel. The perforation rate is about 3%. Colonic atresia is rare. It's evenly distributed throughout the colon. It's a vascular injury, so it's more commonly seen in my experience, in the watershed zones. And it may coexist with other atresias. So if you see one colonic atresia, look real hard for the rest of the bowel for other atresias. Here you can see multiple dilated loops, distal bowel obstruction, and on our enema we have a atresia at the level of the splenic flexure. Functional immaturity of the colon is abnormal colonic motility. It involves infants of diabetic mothers and mothers who received MEG sulfate. Most commonly, there is no association with cystic fibrosis and meconium plug. Here is a patient who has multiple dilated bowel loops, distal bowel obstruction. When we do our enema, we can see that there's a small colon with transition at the splenic flexure to a relatively large caliber colon. This is the typical appearance of functional immaturity of the colon. Now, the one caveat I will put with this is that you must make sure that if you think you have either a meconium plug or a small left colon, that as soon as you do the enema, the kid will start stooling normally. If that doesn't happen, Hirschsprung's disease can mimic a lot of things, and both of these diagnoses can be mimicked by Hirschsprung's disease. Here's another patient who has a meconium plug. You can see that there's multiple dilated bowel loops. There was a failure to pass meconium. When we do our enema, we can see a normal caliber rectum with a plug of meconium within it. Hirschsprung's disease is arrest of the craniocaudate migration of the intramural ganglion cells of the distal bowel. And if you don't have those normal neuronal cells, your bowel cannot relax. So from the point where the arrest of migration is, distally, you will have failure of the bowel to relax. It's a little more common in boys. It's very uncommon in premature infants. It is associated with Down syndrome and also congenital neuroblastoma. Here's a baby, multiple dilated bowel loops, distal bowel obstruction. When we do our enema, we can see that we have a small and spastic-looking rectum. Normally, the rectum should be bigger than the sigmoid colon. This clearly isn't. And we can see dilated, more proximal colon. Here's another patient who has Hirschsprung's disease, and it looks very much like that small left colon, the case that I showed you, so be careful. Hirschsprung's disease, as I go along, it becomes one of the diagnoses that I am very humble about because it's a tough one to make. And the more cases you see, the harder it gets. You can have Hirschsprung's disease involving the whole colon, in which case you have a shortened, featureless-looking colon. It can go back and involve more of the small bowel. The further back it goes, the less well the patient does overall. Usually an impreferred anus is not a diagnostic dilemma. We classify it into high, which is above the puborectalis sling, and low. And the important thing for the radiologist to realize is that there are associated anomalies, especially with the high lesions, in both the spinal cord and in the urinary tract. So you may be asked to evaluate these patients for that reason. Occasionally, the pediatric surgeon will want to know, based on plain films, if it's a high or low lesion, because their surgical approach is very different. And here you can see a baby that has dilated bowel all the way down to the rectum. They want prone cross-table lateral butt-up pictures, and they're basically trying to get the air down distal in the rectum to see if it goes below the line between the coccyx and the pubis, or if it stays above that line. If it goes below that line, it's a low imperforate anus. If it stays above that line, the air is distal, as you can see, it is above that line. You don't know if it's because there's meconium stuck down there and it's a low imperforate anus, but you're just not getting any air down, or if it's high. So you're basically looking to try to confirm that it is a low. Otherwise, you can't tell. Sometimes you'll end up seeing rectourethral fistulas in boys, and the symptom will be that they're urinating fecal material. And here you can see on this VCUG that the child does have a clear fistula between the posterior urethra and the rectum. Girls will never have this. You'll see a rectovaginal fistula in girls. Here's a child that has a tethered cord with a fatty phylum and an imperforate anus, where you can see actually this hugely distended rectum partially visualized on this MR. Common emergent problems, pyloric stenosis. You've heard a little bit about it. It's rare in babies under 1 week or over 3 months of age, but it has been seen in stillborn and premature infants. More common in boys, more common in Caucasian patients. Non-bilious vomiting is the hallmark, very different than the malrotation that is bilious vomiting, and it's due to thickening of the circular muscle layer of the pylorus. Again, disproportionate bowel gas pattern, dilated stomach, paucity of distal gas. The normal pylorus on ultrasound, you can see fluid filled. Here's the echogenic mucosa and the thin, normal muscular layer of the pylorus. Here's the triangular duodenal bulb, normal liver. Pyloric stenosis, they call it the cervix sign. It's an enlarged, thickened pylorus where you can see the muscle is more than 3 millimeters and more than 15 millimeters in width and length, respectively. You'll also see shouldering of the muscle back into the antrum of the stomach. And let me tell you, it's much better to do this by ultrasound than to try to do the upper GI that takes about 6 years to do, because guess what? They have a gastric outlet obstruction. But if you take this pylorus and put it right on here, you can see what we're looking at. Here's the shouldering of the pyloric muscle back into the antrum that gives you your teat sign. You have the elongated, narrowed pylorus. Here's the duodenal bulb. Acute abdominal pain in children is a tough problem. And so when your clinical colleagues are asking you for help, realize that they are dealing with a challenging diagnosis. If you take what the final diagnosis is on a group of kids 2 to 16 years old who came in with acute abdominal pain, the most common thing is we don't know. After that, there's gastroenteritis, appendicitis, constipation, urinary tract problems, but look, we start having pharyngitis and otitis in our list as well. So they're looking for stuff all over the body. Appendicitis is a big deal in the pediatric population. It's common and it's challenging, and the kids didn't read the book, so about half of them present with atypical signs or symptoms. The white count is not elevated in about 10%. Appendicitis would optimally be diagnosed by ultrasound in kids because we're trying to keep the radiation exposure down. Interestingly, the appendix really doesn't grow even though the person does. So we use the same measurements for appendicitis in children as we do in adults. That is a 6 millimeter non-compressible appendix. And if you can see one, here's an appendicolith, a fluid-filled non-compressible appendix, that's great. The problem is that none of our clinical colleagues want to do an ultrasound anymore, and at least at my institution, even if I go in and tell them that there's a appendicitis by ultrasound, they want a CT because they can see it by CT. And different places have different protocols for doing it. We use rectal contrast. I tried to get rid of it and use only IV contrast, and within 1 week, my surgical colleagues were screaming at me. And this is how we do it: 100 milliliters per year of age, up to 1,500 milliliters. And you get beautiful visualization of the colon, and you can sometimes see a nice contrast-filled appendix. And you've all seen the normal and abnormal appendix. Here's an appendicolith, stranding and inflammation, fluid-filled appendix in this patient with appendicitis. Intussusception, big problem in little kids, most common between about 3 months and 2 years of age for the idiopathic type of intussusception. Bowel gas pattern can be anything, and no plain film will make me not do an evaluation for an intussusception, except for a left lateral decubitus where I can see the entire cecum filled up with air. This patient had an intussusception. Here you can see on this prone contrast enema, we can see the filling defect in the right colon. It's a bad sign if you fill the appendix before you reduce the intussusception. Those usually don't reduce. Most of them are ileocolic intussusceptions, and it's due to hypertrophy of Peyer's patches, and then they get caught up by the normal bowel peristalsis and drug into the bowel. Now, if you take a cross-cut across here, you'll end up with the typical target ultrasound picture, and I'll show you that in a second. Colicky abdominal pain and vomiting are the classics, along with current jelly stool. But let me tell you, some of the sickest, grayest kids I've ever seen have had intussusception. They may or may not feel a palpable mass. Abdominal radiographs are important because your only contraindication for doing an enema to try to reduce an intussusception is if there is peritonitis or free air or pneumatosis. So you got to have a plain film to make sure you don't have pneumatosis or free air. It doesn't matter how long the intussusception has been there. That's not a contraindication for an enema. And again, if we cut across, here's the typical target sign, which you have the mucosa, the fat, the sclerosis of the, you have mucosa muscularis, muscularis. You may have some fat from the mesentery pulled into the bowel, into the intussusception. It's most common in the right upper quadrant or along the course of the transverse colon. Ultrasound is very sensitive and specific for the diagnosis of appendicitis. From then we can go on to treatment, and you can either use an enema that's pneumatic or water-soluble contrast. It depends on your comfort level. There is a small risk of perforation. It's actually higher with air than with contrast, but it tends to be cleaner with air than with contrast. If it's not successful, which is about 25% of the time, the baby will need to go to surgery. Incarcerated inguinal hernias. These can present with a bowel obstruction, and you always watch, especially in preterm babies, because their processus vaginalis is not closed, and inguinal rings have not closed, and then they get ventilated, so they frequently end up with hernias, and they can end up with strangulation of bowel down in a hernia. Foreign bodies. Battery foreign bodies are not good, and the other big thing that's out there right now is the magnet foreign bodies that are on a lot of toys. You saw earlier coins that were getting stuck in the esophagus, but The batteries can be very caustic, and the magnets, if there's more than one swallow, they'll stick together in adjacent bowel loops and erode right through the bowel. Very, very bad thing to happen. Liver and biliary tract. Hyperbilirubinemia, jaundice is seen above a level of 5 to 10 milligrams per deciliter of bilirubin. There's two types, unconjugated, which is more of a medical issue, and conjugated, which we get involved with. There's neonatal hepatitis, biliary atresia, choledochal cysts in our realm of differential. The neonatal hepatitis has a variety of etiologies, but you see an obstructive jaundice in an otherwise healthy infant. The liver and spleen may be enlarged. When you image them, their liver typically looks normal. There's no dilatation of the bile ducts, and you do see a gallbladder. If I do see a gallbladder, one of the things I'll do is I'll feed the baby, because that's a nice physiologic test to show that the gallbladder can contract. And if that happens, then you don't have biliary atresia. You have a patent extrahepatic biliary tree. Here's a patient with neonatal hepatitis. We can see a gallbladder, and when they go in and do a gallbladder cholangiogram, you can see that there is a small but patent extrahepatic biliary tree in this patient. Hepatobiliary scintigraphy is done to see if you see excretion into the bowel. You do pre-treatment with oral phenobarb to try to get the liver revved up. And there's three patterns. You can have a normal excretion, you can have normal uptake, but no excretion into the bowel, and that's biliary atresia. Or you can have poor extraction by the liver and poor excretion into the bowel. And that can be seen with neonatal hepatitis, hepatic necrosis, advanced cirrhosis, and in some cases a biliary atresia where you just see poor uptake by the liver and no excretion into the bowel. So here's a typical neonatal hepatitis. At 60 minutes, we see uptake by the liver, we see some excretion by the GU system, but we see nothing in the bowel, but at 24 hours, we see clear bowel activity. With biliary atresia, all or part of the extrahepatic biliary system is obliterated. They have intrahepatic ductal proliferation and periportal fibrosis, but you'll see an obstructive jaundice with conjugated hyperbilirubinemia. And when you look on ultrasound, you usually don't see a gallbladder. You see the triangular cord sign where the gallbladder should be. All you see is echogenic fibrotic material. And usually the liver echo texture is normal. By hepatobiliary scintigraphy, there is no excretion into the biliary tree by 24 hours. This is treated with a Kasai procedure, and we continue to have to image these patients because they get ascending cholangitis, they get portal hypertension, and they usually end up with liver transplantation by 3 years of age. Choledochal cysts are a cystic or a fusiform dilatation of the common bile duct. They're uncommon, and only about a quarter will present with the classic triad of abdominal pain, jaundice, and an abdominal mass. The long channel theory that there's a long common channel between the biliary system and the pancreatic duct with reflux of pancreatic juices back up into the biliary system is the leading theory for the etiology. There's a extensive classification. You don't need to know all of that, but realize that you look for dilated cystic masses adjacent to a normal gallbladder. Here's a cholangiogram showing a choledochal cyst. Here's a CT where you have the normal gallbladder, dilated cystic mass. So this gives me a chance to talk about right upper quadrant cystic masses in children, and you can see that there's an extensive list of differential. All of these things are not uncommon lesions. Cystic mesenchymal hamartomas of the liver, they are often pedunculated off of the liver, and they will present as a right upper quadrant cystic mass. Duodenal duplication cysts, what you want to look for when you're doing an ultrasound of these is the gut wall signature, the mucosa, hypoechoic muscle, hyperechoic cirrhosis. So look on all your ultrasounds if you see a cystic right upper quadrant lesion for that gut wall signature. CSF pseudocysts, not uncommon in patients that have VP shunts. You'll usually see the shunt within the cyst.